Okay, welcome everybody to our Patterns of Practice in Relapsed Multiple Myeloma webinar. This is our first webinar from My Cancer Haven, and I am just going to read out a few housekeeping notes at the beginning. This meeting is being recorded. All attendees have been placed on mute with cameras disabled. Please submit the questions via the Q&A function on Zoom. There are two different functions on Zoom, a chat and a Q&A. So be sure for any questions for the panelists to put it in the Q&A box, and we will address these in the question and answer panel discussion. Use the chat function, on the other hand, to communicate any technical difficulties. And please, at the end, do provide your feedback via survey at the end of the webinar. So this is the agenda for today. We're going to have some introductions, and then Dr. Andrew Yee from the MGH is going to talk about early relapse multiple myeloma, how we treat it, how we think through it. We'll have a panel discussion. Dr. Luciano Costa will then talk about later relapse patients, what options exist, and then we'll have a panel discussion. Dr. Costa will be leaving about half an hour before the end of the meeting, and most of the second panel discussion I will moderate with Dr. Yee. So with that, I just want to introduce the speakers. First, Dr. Andrew Yee. He's Assistant Professor of Medicine at Harvard Medical School and Clinical Director of the Center for Multiple Myeloma at the Massachusetts General Hospital in Boston, Massachusetts, one of the premier institutions in the country. Welcome, Andrew.
Thank you. Thank you, Dr. Vish.
And our second speaker is Dr. Luciano Costa, who is the Mary and Bill Battle Professor in Multiple Myeloma, Director of the Myeloma Program at the University of Alabama in Birmingham, Alabama. He's done some of the pioneering work in transplant and use of novel therapies, and presented some of the latest abstracts in the area of CAR T cells, among others. So we are privileged to have him as well. Welcome, Luciano.
Thanks for having me.
And myself, I'm the Chief Medical Officer here at My Cancer Haven, and also serve as professor at the Washington University School of Medicine and focus on myeloma there. So with that having been said, I'm going to take just the first few minutes to introduce the My Cancer Haven portal to our attendees. I think that most of the attendees would have actually seen the portal, but just trying to give you an overview of the mission. Our mission is to connect cancer patients, experts, and healthcare professionals and organizations on a single patient-centric platform with curated and moderated content. So we are trying to develop a novel paradigm, which when myeloma and then recapitulated in other cancer types. Patients and caregivers, healthcare professionals, all are able to create an account. We have a secure account with the first time the account is created, need for two-factor authentication to make sure that we have security on the platform. We have both mobile and web user interfaces. We have cancer-specific ecosystems, and each ecosystem is pretty much self-contained. And we started out, as I said, in myeloma. We have now got MDS, leukemia, and lymphoma open as well. We provide a number of different services to our patients. We are starting to build a panel of recognized experts so that patients know who the experts are in various parts of the country. We are linking this to their specific own homepages. So if patients want, they can go onto their homepage and get the information needed to make an appointment with these physicians. We are in the process of creating a video library. There are a lot of content on the internet and on other organizations' portals already. We're trying to supplement that with some conversational videos. And what we are trying to do is actually even highlight the content produced by others in our videos. Patients and caregivers are allowed to submit a question, and we as administrators of the portal try to answer these questions on our blogs. We have a patient community, and as far as the patient community goes, this is something that has a few different features. We have blogs, which are healthcare professional created blogs. These blogs, patients do not blog. It is mainly experts and healthcare professionals who talk about the latest developments that we are able to then get to patients. We capture tweets from not patient advocacy organizations, not-for-profits, and key opinion leaders. We also have news that is cancer type specific. So if you're in the myeloma ecosystem, you will get only news specific to a particular kind of cancer. And the news gets updated by the minute as it flows in. We have support groups that we support, but also any individual can form a group on the platform and act as the administrator of the group. Patients can message one-on-one. They cannot message healthcare providers or healthcare professionals, but can message other patients. We try to get the patient's perspective by posing questions to try to see what is of importance to the patient community. We also have a feature which we call the sanctuary, where patients can keep a private journal and also keep a track of their appointments. Also, we send out newsletters. We send out one called the MCH Digest. It used to be weekly, now every 2 weeks, informing people about upcoming initiatives. And the MCH Minute, which goes out on Thursday mornings, is a self-generated email that gathers all the new content on the portal in the last 7 days. It has links that can take you directly to the content that you wish to read or videos that you wish to see by clicking on the links. So I think what we'll do is we'll just have some polling questions to get started. So Navya, you can enable the polls. Okay, see the polls come up. Okay, so first question is, who are you? You're a patient, a caregiver, or other? We'll capture the answers and for our own analysis. Give a few seconds and okay. Can put up the next question, Navya. Okay. Okay. Next question. Okay, how old are you? 40 to 50 years, 51 to 60 years, 61 to 70 years, 70 to 80 years, or above 80 years of age? We can move on to the next question. What region of the United States are you located in? The Northeast, the Southeast, the Midwest, or the West of the United States? Okay. Well, okay, I guess we can move on to the next question. What is the useful resource for your cancer journey? What kind of resource would be most useful for you, for the organization to provide disease state education, access to experts, peer support, psychosocial support, or financial support. Okay. Now, let me see. Is that the last question, Navi, or is there one more? Let's see. I think that may be the last question. Okay, we can move on then. Okay, there is a last question. I thought so. Okay, if you're a patient, what line of therapy are you on? First line, second line, third line, fourth line, or fifth line? Okay, I think we can get going. So I'm going to now turn over the podium to Dr. Andrew Yee, who's going to talk to us about navigating early relapse in multiple myeloma, what regimen is right for you. Welcome, Andrew, and take it away.
Right. Thank you, Dr. Vision, and thank you and Mike Cancer Haven and the sponsors for organizing this. I think it's a really I'm glad to have a chance to share some of the exciting new developments in how we treat multiple myeloma, and I'm also pleased to be able to share the stage with Dr. Costa as well. Next slide, please. So this is like an overview, as many in the audience already knows, about some of the basic. Like when I see a new patient, I tell patients about how myeloma is not a very common cancer, compared to breast cancer or lung cancer. But when patients hear about the new diagnosis, they are they've never heard of it before, but then as they become more familiar with the diagnosis, they start to encounter more and more people who have the diagnosis and who are living well with the diagnosis. Next slide. And this slide here illustrates some of the really, some of the dramatic developments that we've seen in multiple myeloma care, which have resulted in improvements in how patients are doing. And I think one of the slide here points out really how a lot of these developments have really happened in the past 10 years and really more so in the past 5 years. And I think what's really exciting when we take care of multiple myeloma is that we have all these exciting new options available. And when we go to these meetings, we always hear about these new developments. And I think what's also exciting is that we hear about these new developments, but we can actually apply them in practice for our patients, and we can actually see the gains, the kind of transformations that can happen with these really new effective therapies, really compared to when I first started. Next slide. And so I know we're talking about relapsed multiple myeloma, but we think about, for newly diagnosed multiple myeloma, I think about how this is, kind of it's kind of a journey, and patients generally are on some kind of treatment for extended periods of time. And for many patients, the first year is, you're getting to hear about the diagnosis, thinking, I mean, it's a life-changing event to hear about the diagnosis and the treatment. And I know the first year, it's front and center. And the hope is that for many patients with treatment, you can eventually put it on the back burner, so to speak. And for newly diagnosed patients, yes, it's really involved. We do think about, a traditional categorization for patients is we think about the use of high-dose melphalan autologous stem cell transplant. But aside from that, the initial therapy doesn't necessarily change that much. We generally think of with everything about initial therapy, and the initial therapy can range from 2 to 3 to 4 drug combinations. And increasingly, we are using 4 drug combinations with the CD38 antibody as part of its initial therapy. And that's changed a lot really in the past 5 years. And about 5 years ago, we were thinking 3 drugs were standard, but now increasingly we think more about 4 drug regimens. And that also some of Dr. Costa's work has paved the way for that. For patients, we think about, for eligible patients, we incorporate stem cell collection and high-dose melphalan. And then we talk about maintenance therapy. So one thing that separates myeloma therapy compared to other types of malignancies is this idea of maintenance therapy to maintain the response. Since myeloma is not curable, but it is very treatable. And with maintenance therapy, patients can enjoy long periods of sustained disease response. Now, the challenge though is that some patients can, patients over time can relapse. And it's really hard to predict when you first meet a patient, are they going to be able to continue on the same maintenance therapy for years, or is there relapse? Does that occur over a shorter period of time? But thankfully, we have all these exciting new therapies to address disease when it relapses. And for some of these patients, the therapy that you get at time of relapse offers a better response than your initial therapy. And that's what's really so exciting about myeloma care, is that, some of these newer therapies that from clinical trials that we hear about at meetings and then eventually get approved, we can apply them to clinical practice. So next slide. So when we think about relapse, we think about distinction between clinical relapse versus a biochemical relapse. And the clinical relapse is a relapse where there's something that the patient may experience. So sometimes the clinical relapse can be a new bone lesion that causes symptoms, or maybe the patient has increasing fatigue and it becomes apparent that the patient has worsening blood counts, or maybe worsening renal function. So that's a clinical relapse where the disease is presenting in a way that the patient may experience as a symptom. And then there's the biochemical relapse, where a biochemical relapse is where you have changes in your myeloma-related parameters, such as increase in the monoclonal protein, increase in free light chain, or increase in the urine monoclonal protein. And I think what's different about the clinical relapse versus the biochemical relapse is that when patients, when someone's diagnosed with multiple myeloma, you're getting these labs checked a lot more frequently. You as part of your routine standard practice when you're coming in for visits to see like Dr. Vij or Dr. Costa or myself, you're generally getting these myeloma-related labs checked on a pretty frequent basis. And because they're being checked on a more frequent basis, you can generally, relapses are generally biochemical. So I think about 2/3 of patients, when they have relapse, it's generally detected at an earlier stage when it's a biochemical relapse before a clinical relapse occurs. Next slide. And these are things we think about when we think about treating relapse disease. And these principles also apply to newly diagnosed patients as well. So some of the themes are the same. So we think about patient characteristics. We think about how what's the patient's functional status and their previous therapies that they've received. Now how active they are and how much support that they need. And we also think about patient preferences. Some patients may prefer a regimen that isn't as burdensome, like regimens that use more oral medications. And so there's a lot of heterogeneity as we're doing this, since there's a lot of in doing this, there's so many differences between patients. It's really hard to predict what patients want until we actually talk to them, right? That's part of clinical care, is that you can't just do this based on AI or a robot or a machine. You actually need to talk to the patient in front of you and their caregivers to see what are their priorities. We also think about disease-specific factors. So we talked about the biochemical relapse versus a clinical relapse. I think for patients who have a clinical relapse, you might lean towards a therapy that has a little bit more juice to it, so to speak. And then we think about the timing of the relapse, earlier versus later. I know this session we're talking about early relapse. So a patient who is on maintenance lenalidomide and is relapsing 5 years into therapy is different than a patient who is relapsing 1 year into, say, daratumumab lenalidomide maintenance. So that feels a bit different. We think about the timing, is it increasing rapidly? We think about the clinical features, and then increasingly we are thinking about there's some potentially actionable alterations. So for example, we're starting to hear more about translocation 1114. That's potentially actionable for very specific therapies. And then we also think about some of the therapy specific factors in terms of how is it given? Is it given, intravenously, subcutaneously? Some of the therapies, as you hear about Dr. Costa talk, and when Dr. Costa presents, some of these therapies may require an inpatient hospitalization. Some of these therapies require a caregiver to be present. We also think about, and intrinsic to the therapy, some of these therapies have different side effect profiles as well to think about. Which I'll get to when I start talking about the therapies. Next slide. So this slide is kind of it's a little busy, and I don't think you can't really read the small print. And the whole point here is that when we have relapse disease, it's an area of active investigation, and we have all these clinical trials which have provided data that we can start to apply to clinical practice. And here are some Here are some of the newer therapies which incorporate an anti-CD38 antibody that can be relevant to lenalidomide refractory patients. So when I think about patients who are in early relapse, increasingly, since patients are treated with lenalidomide, we have to think about therapies that can be applicable to patients who have had prior lenalidomide exposure. So here are some examples of 4 different trials. So on the left-hand side, we have trials which incorporate anti-CD38 antibody with the oral medication pomalidomide, and pomalidomide is a next generation lenalidomide. And then the right-hand side, we think about anti-CD38 antibodies combined with the proteasome inhibitor carfilzomib, also known as Kyprolis. And something to point out here with these clinical trials is that the carfilzomib here is given twice a week. And in current practice, we've shifted towards giving it once a week. But I show this data here. It sets the stage for future discussions. Next slide. And here, it's a little bit also kind of busy, but it sort of summarizes the differences in efficacy. So like off the bat, you can see on the combinations which use carfilzomib or Kyprolis, they tend to have higher responses as well as higher durability in terms of progression-free survival. So for example, if you look at the one regimen, the ISA-KD, it has some of the highest and longest progression-free survival events of any of these regimens. And it turns out here, I show it's like 36 months. It's been updated, it's 42 months. So that's some of the highest response rates and longest responses we've seen for a relapsed regimen. Now, a couple things to point out is that just to provide some additional nuance to this is that the regimens with pomalidomide, which is the daratumumab, pomalidomide, and dexamethasone, and the isatuximab pomalidomide, those trials, all those patients have had prior lenalidomide, whereas the carfilzomib-based trials, only 40% have had prior lenalidomide. So it's somewhat of a different patient population. Next slide. Now, so initially when I heard about this data with like Candor and Akima, these carfilzomib-based regimens, initially I was thinking, well, these are only 40% of the patients had prior lenalidomide. But it turns out that if you looked at the lenalidomide refractory subset, so again, this is relevant for patients, if they've had lenalidomide or Revlimid as part of the initial therapy and they're in Revlimid maintenance, these are some of the numbers in the subsets that are probably potentially relevant. So we think about the carfilzomib-based cohorts, you can see that the progression-free survival is maintained even if you're lenalidomide refractory. Next slide. Now, so something also to point out is that when we think about choosing these regimens, there can be some differences in the side effect profile. So the regimens that use pomalidomide tend to have more myelosuppression, which means neutropenia and thrombocytopenia. So those are things we think about in terms of their neutrophil counts tend to be more affected when you use a pomalidomide-based regimen in combination with the CD38 antibody. Now with carfilzomib, in these earlier studies, when I talk to patients about carfilzomib, one thing to appreciate is that carfilzomib can be associated with heart dysfunction, which can be associated with shortness of breath. But in current contemporary practice now, these trials were presented like about several years ago, and these were twice-a-week regimens. But in current clinical practice, when you use it once a week and attention to not overhydration, the heart failure hospitalization rates, it's much less and it's not as high as what we see here. So in current practice, yes, it's it's something to think about, but I think in current clinical practice, it's not as, I don't get the sense it's as high as what was presented in these earlier studies. Next slide. So here's just one approach. It's not the only approach. It's one approach to clinical practice. And I think, there's not going to be a head-to-head trial looking at anti-CD38 antibody pomalidomide versus CD30 antibody carfilzomib. I don't anticipate that will happen, but this is when I think about these regimens, I think, yeah, if there were a head-to-head trial, that one was, if that actually happened, I do think that the carfilzomib-based regimen would probably have more PFS and deeper responses. But then we think about some of the other characteristics. So I think, a daratumumab subcutaneously based regimen, or daratumumab was approved subcutaneously in 2020 with pomalidomide. For many patients, it can be a more convenient regimen. Whereas, with the carfilzomib based regimen does involve weekly visits, at least in the beginning, because I think over time we can't do it every other week. So there is a component where there's a little bit more of a burden to the patient. But having said that, for patients where you have an earlier relapse, or you have lytic bone disease, like a symptomatic relapse, I would lean towards a carfilzomib-based regimen with a CD38 antibody like daratumumab or isatuximab. And always I think about clinical trials. So I think clinical trials are how we give patients access to some of the most exciting therapies that we have, as well as that's how we think about moving the field forward. Now, one thing to think about in clinical practice is that sometimes a lower dose of pomalidomide can be helpful, and attention using growth factors to support patients who have neutropenia. And then certainly when we're giving these carfilzomib-based regimens, I think giving it weekly makes a big difference in terms of for patient convenience and the overall experience. Next slide. So those are some regimens that use, pomalidomide, they use carfilzomib, they use CD38 antibody. But then we have to think about, increasingly as patients have, you've had CD30 antibody exposure, we have to think about other regimens as well. So here I'll just highlight a couple approaches as well. And one approach is with cyclophosphamide-based combinations. Next slide. So a commonly used regimen. So a common scenario would be, suppose you had daratumumab, pomalidomide, dexamethasone, and you have a relapse with that. What do you do next? So one approach, outside of the regimens that Dr. Costa will be talking about, would be to think about incorporating cyclophosphamide. So here we have a regimen that uses carfilzomib and cyclophosphamide and dexamethasone versus carfilzomib and dexamethasone. And here you can see in this lenalidomide refractory cohort that you can have significant improvement and augmentation of the efficacy with the addition of cyclophosphamide. Next slide. And certainly you can also combine cyclophosphamide with pomalidomide. So here is an older regimen that was presented, that was published in 2016. I looked at pomalidomide, cyclophosphamide, dexamethasone. So I think the theme here is that I think with myeloma therapy, we're fortunate that we have all these different agents, and most of these agents you can combine together and have increased efficacy. And I know at this upcoming ASH meeting, there's going to be more data presented on using pomalidomide, cyclophosphamide, and dexamethasone. Next slide. And then I also do want to talk about selinexor as another regimen. I think about when I think about these regimens, the regimens I was just discussing, these regimens are available that in smaller practices and practices in the community. So some of the therapies that Dr. Costa we talk about really are mainly given to you at a major medical center or require more support. And I just kind of wanted to comment on regimens that patients can have, in a community, in a more of a community-based practice. And one of these regimens can incorporate selinexor. Next slide. So selinexor is an oral medication, and this is a medication that blocks this nuclear export protein. So essentially, this keeps tumor suppressor proteins inside the nucleus so that they can be more effective as tumor suppressors. And this regimen using selinexor and dexamethasone was approved in 2019. But a limitation with selinexor is that it can be associated with GI side effects such as nausea, and it can be associated with vomiting. And when I think about these regimens, when they get approved, that's just sort of our first experience with these regimens. But over time, as we get more comfortable using them, we tend to combine them with other therapies so we can maintain the efficacy as well as improve the improve the efficacy as well as improve tolerability. So all regimens of myeloma therapy, they over time, we adjust them so that they become more user-friendly for patients as well as potentially more effective. So next slide. So Here's an example of a regimen which it looks at selinexor combined with bortezomib dexamethasone. And something to point out with this study is that the control arm with bortezomib dexamethasone the investigational arm with selinexor had half the amount of bortezomib compared to the control arm. And even though at half the amount of Velcade, you were able to see this increase in efficacy as well as improvement in tolerability compared to compared to the previous dosing with selinexor. I think the theme that I wanted to point out is that with selinexor in current contemporary practice, it's really we're using in combinations either with carfilzomib or with pomalidomide, so you can have this excellent efficacy as well as improving the tolerability. And these are regimens that you can have that are available to you in the community while you're potentially awaiting access to some of the newer therapies. Next slide. So here are some NCCN guidelines, and I think whenever we show these guidelines, are always they're always changing, right? Because we have all these new developments. But here are some of the regimens that we discussed, and I think some things that would point out would be, for example, I think some of the cyclophosphamide-based regimens I don't think they've made it to the NCCN guidelines, or some of the other selinexor-based regimens. Next slide. So I think one of the themes is that we have all these new therapies that have evolved over the past few years. And for patients who have relapsed, some of these regimens can be really effective in getting disease back in control and getting people back into remission. And the therapy that we choose together really is based on patient characteristics, how their disease evolves, as well as thinking about the mechanics of the regimen as well as the side effect profile. And I think at the end that it translates into better outcomes overall. So thank you. That concludes my comments. Thank you.
Thank you very much, Andrew, for that excellent presentation. So we're going to now have about 25 minutes odd to take questions. Please, for attendees, put it in the question and answer box on your Zoom platform because we have silenced the mics. Luciano, obviously, Andy gave us a great presentation on how we treat early relapse. You're going to tell us later about late relapse, but how do you approach early relapse? Anything that you would do a little different, or because there's great differences in practice, not only, as Andy said, a physician himself choosing what to give a given patient, but also differences between how physicians practice, and there's no right or wrong answer.
Absolutely, and there's of course a lot of variation among ourselves. I think we all, for the most part, weight in the same elements, which is what patient has been exposed to, how the patients tolerate therapy, any comorbidities that might influence the choice of one therapy versus the other, and last but not least, less important, patient preference. I think there are a few principles that I use as guidance. One is we introduce an anti-CD38 monoclonal antibody as early on the line of therapy as possible. So nowadays, most patients who we see who have a first or second relapse, they initiated their therapy many years ago before CD38 antibodies made to the first line setting. So they have not been exposed to that yet. Then I would go ahead and tend to introduce it. What to partner that with depends very much of what the patient is progressing on or progressing after. Most commonly, people are progressing after lenalidomide maintenance. Then we tend to use either as a third generation immunomodulatory agent, in case pomalidomide, or switch class completely and go with a proteasome inhibitor. And I do consider, I think many of us does, carfilzomib to be the superior proteasome inhibitor in the relapse setting. And we tend to partner with that unless there's some great impediment in terms of comorbidities and so forth. The things that I find more challenging actually are the patients who now becoming more and more common in our practice, who receive a CD38 monoclonal antibody as part of the initial therapy, and they are experiencing a first and a second progression. They have been exposed to prior CD38 because those patients were not reflected in any of the trials that we have and very kindly and comprehensively discuss. So we of course we tend to, those patients we know tend to have a more short and unsure response. We tend to, of course, always possible introduce at least one agent with a mechanism of action to which the disease has not previously been exposed. But I find those patients to be very challenging because, because of in part because of the near complete lack of data. But I'll be interested to hear how you guys approach it.
And I think that there's, as we said, no right answer here. And obviously, I'll put it to Andrew. So you did talk about biochemical relapse, and a lot of patients in second-line therapy are biochemical relapse. They're doing fine. Fortunately, in myeloma, we have a blood test that picks up relapse either based on what we call M protein or light chain much earlier than they would feel anything going wrong, or their kidney function or their x-rays suggest any changes. So you mentioned you still use a CD38 antibody, but at what time do you, in a biochemical relapse, decide to act? Andy?
Right. So that's a complicated question. I think it depends on, some patients can. It really depends on the tempo. I think it's a combination of factors. And I know I've just done a lot of hand waving so far. One would be, I think about the clinical characteristics of the patient. Like the patient had a lot of lytic bone disease or had renal dysfunction, then my threshold to act on a biochemical relapse is lower, in the sense that I would be more prone to treat somebody earlier in their biochemical relapse rather than waiting it out. So that would be one factor. The second factor would be, if they had high risk FISH, if they had, 414, deletion 17p, if they had a biochemical, I'd be more prone to act on those patients. A third consideration would be from a practical perspective, and I know you guys can speak to this as well, would be, we think about clinical trials as well. And when we think about clinical trials, sometimes the next potential best therapy would be a clinical trial. And so from a practical perspective, to get onto these clinical trials, albeit like CAR T or bispecific antibody, requires measurable disease. And so, sometimes that would mean like a monoclonal protein over 0.5 gram per deciliter, or a light chain over 100 milligrams per liter. So in some cases, the time point to treat it would be framed by the eligibility criteria for a clinical trial. Now, in some patients, if the M protein goes from 0.1 to 0.2 and it's been like 6 months, I think I'm fine generally observing. I think if it was, 0.1 to 0.5 in 2 months, then I'm more thinking, okay, maybe this is something more active. And in addition to that, I also think about incorporating more imaging in those patients just to feel out, does this have any other clinical characteristics? So in patients where the M protein is rising, to just better characterize, is this truly only a biochemical relapse, I would think about incorporating more imaging. So sometimes that can vary from institution. You could be whole body low dose CT, could be a PET CT, could be an MRI. Because certainly, if you had a new lesion on imaging, then that would provide further justification for acting at that point in time. I also just wanted to mention about the biochemical relapse versus clinical relapse. When people have looked at these patients, like how they do overall, there's a study that was out of Mayo Clinic, and they looked at treating patients at time of biochemical relapse rather than waiting at clinical relapse. And initially, when I saw that data, I was thinking, well, it's because those patients with biochemical relapse had more benign disease features. But it turns out that the patients with biochemical relapse and clinical relapse, they actually share overlapping characteristics in terms of ISS stage or cytogenetics.
So, Luciano, what about yourself? How do you approach the typical biochemical relapse where the serum markers are starting to suggest early relapse, but nothing else is going wrong yet?
It's very interesting. I was listening carefully to Andy, and it exactly reflects my my thought process. I think particularly us who spend a lot of our time taking care of patients enrolling therapeutic clinical trials, we start thinking, not only what I'm going to do next, but how can we go above and beyond and trying to bring a new therapy to these patients. So thinking clinical trial eligibility is often a big part of our thought process. I would only say, of course, there's no generalizable rule ever in myeloma. And a question that I often get asked by patients and sometimes by the fellows is, how high the M spike needs to be to start treatment. And as Andy very well pointed out, there is no such an answer. You have patients who present with an M protein of 7 grams and anemia only, so that patient, I'm more willing to look past an M spike of 0.5, 0.8, 0.9. Particularly if it's November and Christmas coming up, there's no point of rocking the boat. As opposed to somebody, we have people with horrible bone disease that all they produced was an M spike of 0.9 and a light chain of 150 at the time of diagnosis, right? For that patient, more likely to react to even minor increments of the paraprotein. The other thing that I think is, I feel in a way, as time goes by, I feel more in maintenance therapy becomes more of a fixture in myeloma. I tend to be more inclined to change therapy with with biochemical progression as opposed to clinical progression, because I think from the patient experience standpoint, if you're doing observation, you're going to start a new therapy. It's completely life changing. But if you're already on therapy, I see that as not only, I see that as discontinue a therapy that is expensive, toxic, and no longer working to start something better. So I find myself easier at, switching therapy at a biochemical progression, somebody who's already on some treatment as opposed to somebody who's completely on observation.
So the other end of the extreme from biochemical progression is often a patient who has, high-risk disease, as we call it, either because they have chromosomal abnormalities that portend for a more aggressive course, or instead of going 4 or 5 years at their first line, they get only a year or 2 with their first line of therapy. So Andy, these high-risk patients, do you approach them any differently?
Right. So I think, for these high risk patients, I think more about being more heavier with the treatment. So I think in terms of if they didn't, if somebody had a had a relapse within a year and say it was like a biochemical relapse within just 1 year and they had high risk, then I would think about, say like using that regimen and they were CD38 antibody naive, then I would think about, like the isatuximab, carfilzomib, dexamethasone regimen that we were just discussing, or participation in a clinical trial, since now we're doing clinical trials with some of the bispecific antibodies that Dr. Costa will be discussing. So for patients who have a that kind of a relapse, then I think more about that regimen. Now it gets trickier, as Dr. Costa was pointing out, about patients who are, say they had Dara-RVD transplant and on Dara-R maintenance, and then they are relapsing on Dara-R. That gets really complicated because there's not really there's not as much guidance in terms of how do we approach those patients. So that for those patients who are already having that, then I think about, using carfilzomib, pomalidomide, dex would be one example. Sometimes that's where the cyclophosphamide-based regimen comes into play. I think for those patients who are relapsing really quickly like that, which is thankfully not, it's a smaller proportion of patients. I think some of these newer therapies like CAR T cell therapy can play more of a role. And I think for patients in the community, I think that would be a good juncture to perhaps think about connecting with a facility that is able to offer some of those newer therapies, because I think for patients who have an early relapse, some of those therapies with the bispecific antibodies or the CAR T cell therapies play more and more of a role. And I think one thing we didn't mention is that occasionally some patients who have really aggressive relapse, then we think more about, more traditional chemotherapy type regimens that, could be like DSAP, VDD PACE, a pulse of cyclophosphamide. So sometimes there are those patients where you need a regimen like that just to get them over the hump.
So these are obviously old chemotherapies that have been around for 40 plus years, but often do a great job even when our modern therapies fail. It's just that they're a little more toxic, correct?
Yes, yeah. Those, I think those older regimens are sometimes can be really effective for somebody who has really highly proliferative disease. But as you mentioned, they can be burdensome and they're more associated with myelosuppression and risk of having infection. So they have more side effects. So that's why we only reserve them for patients who have a really aggressive type relapse.
So Luciano, what about yourself? Those who are high risk patients, early relapse, how do you approach them?
Yeah, so that's very important. I think we sometimes, of course, we all very quick to celebrate the advances and the multiplicity of therapies that we have for myeloma. But it's important for us to keep in mind that every relapse is a challenge. Every relapse, there's a component of unknown. You can never guarantee the myeloma is going to behave the same way it behaved before. And unfortunately, we see, particularly those high-risk patients, sometimes patients don't do well, end up hospitalized with the renal failure, fracture, significant bone disease causing pain. So particularly in those high-risk patients, we take those progressions kind of very seriously. And that's where we have to, change the priorities. The priority becomes a quick and sure response as opposed to convenience. You can always take a step back later on once you have kind of conquer that initial challenge. But the priority then becomes, have a sure response and have a quick response. So I agree with Andy that we're going with triplets every time we can. Delivering full doses, sometimes despite cytopenias, in order to get through that initial 1 to 2 cycles, give the patient as much support as possible, and then later on pull back when you and then intensify the therapy if possible. But if you don't get over the initial hump, then you can compromise the patient's safety eventually.
So we have a question from the audience saying, please define aggressive relapse. So how do you define aggressive relapse, Luciano?
Good questions. I think one thing is to say is you have a present or imminent risk of organ failure, a patient with a very fast increase in biomarkers, particularly light chains that are, 1,000 or crossing 1,000 are putting the patient at risk of renal failure. Or patient who is very symptomatic with pain, or a quick reduction in blood counts, fast onset of low platelets or anemia. I think those are all features that we learn to recognize as being an aggressive progression, a progression that is happening shortly after very intense therapy. For example, if you finish a quadruple regimen, and then 9 months later the patient is progressing, that is considered aggressive by nature. And that is in contrast to somebody who is on the same lenalidomide maintenance for 5 years, and now you see an M spike go from 0.1 to 3 months later 0.2 to 3 months later 0.3. That will be the non-aggressive relapse, if you will.
Andy, anything to add to that?
Yeah, I completely agree. I think other things to point out, like somebody who has hypercalcemia, kidney, if you had worsening kidney function, your creatinine went from 1 to 2 to 3, that I would think about that as aggressive, relapse. And I think the challenge is for those patients, those patients don't necessarily have time to enroll in the clinical trial. And so that's where some of these older fashioned chemotherapies can play more of a role because that's something you can give in relatively short order, as well as patients who have a lot of extramedullary soft tissue disease. So you have extramedullary, pleural effusions, extramedullary disease in terms of in the internal organs. That can also be features of an aggressive relapse. And I think that's one, for all of us, I think that's one of the core challenges in how we take care of these patients.
Yeah, as you said, hypercalcemia meaning high calcium, and extramedullary relapse meaning relapse outside of the bone marrow. Patients often come with, large masses, and sometimes you get a false sense of security just looking at the blood test. Often it's later in the course of the disease that these patients become even non-secretory, as we say, that they don't have reliable blood markers. As far as extramedullary disease goes, obviously it's something that is increasingly being talked about in medical circles, in myeloma experts. Luciano, do you treat extramedullary disease any different?
Yes, I think the short answer is yes. I mean, extramedullary disease often comes along with other features that we already consider to be, high risk disease, such as a very fast tempo, a very fast pattern of biochemical improvement, or hypercalcemia or cytopenias and so forth. I think in those cases you use essentially the best regimen you can get your hands on, the most intensive regimen you can get your hands on. I think when we're going to talk in the next session, but I think some of those novel therapy, particularly CAR T-cell therapy, seems to perform particularly, I wouldn't say particularly well. I mean, it doesn't perform as badly as expected because most things don't evolve very well. And that's one of the situations where we oftentimes reach out to older regimens with combination chemotherapy, particularly as a short-term approach to get the patient out of a crisis, so to speak, and be able to transition to a more sustainable and enduring therapy.
So one of the questions also posed here, Andy, is would you use Kyprolis and dexamethasone in a patient who has atrial fibrillation and an ejection fraction decrease?
Right. That's a complicated situation. Not uncommon, though. Not uncommon. So I think, if somebody had, heart failure and, if somebody had active heart failure type symptoms, or say was just in the hospital for heart failure, I probably would be I would probably lean on something else first rather than using carfilzomib. And so sometimes if a patient didn't have a proteasome inhibitor before and doesn't have significant peripheral neuropathy, then I would think about using bortezomib in that context rather than carfilzomib. I think if they've already tried that and, carfilzomib was the one agent that they haven't had, and assuming that the heart failure, the history was relatively well controlled, I think you could use gently introduce carfilzomib, but not necessarily, you could probably ease your way in, like say 36 milligrams per meter squared or 45 milligrams. You can probably use a lower dose and see if they achieve response, and just to test out and make sure that they don't have any worsening, any exacerbation of their heart failure. But it's a situation where you can use it, but I think you just have to use it just cautiously and be more attentive to how the patient's doing. I think, you can use, in addition to seeing how the patient's doing, you can monitor NT-proBNP, for example, as another indicator for heart failure for patients from carfilzomib.
So, Luciano, Andy talked about different factors that we consider when choosing a regimen. It's as much art, it seems, as it is science. And we've been discussing, biochemical relapse, more aggressive relapse. But often it may be that the patient's own preferences may play a role. What do you face when you see patients in terms of requests from patients? All oral regimens, minimizing doctor's visits, minimizing the number of the time that is spent in the doctor's office. How do you go about incorporating that into your decision making?
No, absolutely. Of course, I always tell patients we provide advice and provide services, but ultimately they are the decision makers. All we do is to help them organize their thoughts and provide information and help their way into all the different options. But not surprising, I think patients oftentimes have very similar priorities and value things in a very similar way than we do. They understand their disease well. They understand what they're up against, and yes, and everybody wants a more convenient lifestyle. Everybody wants to spend more time, traveling and seeing the grandchildren than in the office seeing me or Andy or Ravi. But ultimately, people know that to get out those things, we need disease control. So I think with very few exceptions, a patient wants to be sure their disease is going to be controlled and they're going to be able to move on with life before they prioritize, other things. I always take to myself, and I think patients feel the same way, that time in the office is time stolen from their lives in a way, so we try to make the time on the chair to get treatment as quick as possible. I think one thing we didn't discuss much today, but for example, for the carfilzomib containing regimens, they mostly have been developed as a twice a week infusion, which is a lot of time taken from the patients. So there's quite a very reasonable data that allow us to extrapolate once a week dosing, and so we often do that. Patient wants to feel well and have their disease under control. So some symptoms that we tend sometimes to pay a lot of attention to, like low blood counts, for them not necessarily means a whole lot if they still feel well. So things like changing taste, diarrhea, rashes are things that people pay a lot of more attention to and are more willing to make treatment decisions around. And we, of course, always help them try to weigh the pros and cons of toxicities versus treatment efficacy.
So last question before I move over to the second part of the presentation. So to you, Andy, another question that came in is, how do you decide Pomalyst dosage? You mentioned 3 milligrams. Here is asked 2 or 4 milligrams on second-line treatment with Darafastro.
Right. So, so the clinical trials of pomalidomide, either the doublet or in the combinations, have used 4 milligrams. But I think there is a fair amount of neutropenia, as you can see from the data. So I've tended to use 3 milligrams rather than 4 milligrams. Now, you could, I think if you wanted to do 2 milligrams, I think that's fine too, but I might lean towards 3 versus 2. I mean, I think there is some data suggests that 2 and 4 may not be that different. I think one thing with myeloma therapy is that you can actually, we have ways to monitor your response, right? So you can know if you, if the dose is effective or not. And I think if some patients want preferred, I think that's fine too. The other thing to realize is that some patients also, I think in the beginning, it's important to support the patients through the therapy, and use of, growth factors like, GCSF can be really important to maintain their neutrophil count. But I think there can be a lot of variability. So I bet Dr. Vish or Dr. Costa might have their own opinions about 2 versus 4 versus 3 milligrams.
No, I think that I totally agree with you. The dose hasn't been vetted very properly. I think that initial trials capped it at 2, and then with a modification, they went up to 4. I personally agree with you that giving 4 is a little harsh for most patients, and I tend to often use 2 rather than 3. But what about you, Luciano? How do you do it?
Yeah, I'll answer that, and maybe that could be a segue to the next session. I think the same considerations that you and Andy made. I think for patients, what I tell them is important: do not feel bad if your dose is down to 2 or even down to 1. Particularly for IMiDs, there is really no convincing, which are drugs like Pomalyst, there's no convincing data out there that, dose is that important, that 4 is better than 2. And you have to, I always tell patients, remember the very same trials that gave the evidence that guide us now, that show that this works, as well as it does, had a lot of dose reduction. So that is part of the trajectory. And very few patients are on full dose 4 milligrams, 6 months or 12 months down the road. So don't feel bad. Don't feel like we're missing out if we have to reduce the dose.
Okay,
Absolutely.
well, going on to your presentation. So Luciana, take it away. Absolutely.
So I'm going to talk to you now about the circumstances where patients have received 2, 3 more regimens throughout their journey. And we're dealing with myeloma that is more refractory, and particularly discuss some of the innovations that have occurred in this field with new classes of therapy. So if you can move the next one. So I always discuss with patients this landscape. So the way we think, you heard that from Dr. Yi and Dr. Ravi, is we really organize our thoughts for newly diagnosed and early lines of therapy across those 3 pillars of therapy, which are the proteasome inhibitors, the immunomodulatory drugs, and the anti-CD38 monoclonal antibodies. So there are some differences between agents within the same class, but very importantly, those are the 3 main classes that we have. And the myeloma eventually becomes resistant to at least one agent of each class. And if you move to the next one, you can imagine that when that happened, that's not good news, because we're always trying to reach out for the class that the disease is not refractory yet. So I think, Dr. Vij and several other colleagues across different institutions in the United States, a few years ago, we put together this project where we gather over 200 patients whose disease had become resistant to an anti-CD38 monoclonal antibody, for example, daratumumab. And what you can see is if you just use the therapies that were available at the time, 5 years ago, for patients who had disease refractory to all 3 classes, the outcome was very poor, and patients live in average 9 months. And I often show this data or data like this to the patients to not to scare, but put things in perspective, because as we talk about novel therapies, bispecifics, CAR-T, and others, they can be a little bit intimidating, a little bit complex. And sometimes it's like, I'm doing okay. I'm just now, my myeloma is progressing on, a Dara Pomdex. My number went up. Why do I need to jump into all this? And I try to put this in perspective, what we're up against, right? Essentially, we can always recycle the same classes or bring up a different combination, but the likelihood of response are not that high. So if you move to the next one. So in this scenario, we have, fortunately, new therapies to go after. And I think very few things have been so talked about in myeloma ever as CAR-T cell therapy, and rightfully so. So this is a therapy where we extract from the patients T cells. And I explain to patients often that T cells are cells that our immune system produces that are specialized in killing other cells. And that is a natural phenomena in order to eliminate cells that have been infected, for example, by a virus. But of course, we don't have in our body T cells that automatically get rid of myeloma, because myeloma is essentially a corrupted normal plasma cell. Otherwise, we wouldn't have myeloma in the first place. So the challenge here is, how do we take T cells from our immune system and repurpose those T cells or redirect those T cells to now fight the cancer? And the very ingenious solution that took decades to be developed is essentially take some of the T cells out of the body through a process called apheresis. And many times patients have had an autologous transplant, so they can relate to apheresis because they have had that procedure before. We take cells from the bloodstream. Those cells are properly grown into the lab, into more cells, and they are modified genetically to now being able to express a receptor that can bind to a protein on the surface of the myeloma cell. And for the two CAR Ts that we have currently approved, that protein happens to be a protein called BCMA, or B-cell maturation antigen. So in the end of that process, you have a batch of cells that were made from the patient's own T cells that have been engineered to recognize those the BCMA. And those cells have what we call, this receptor has what we call the co-stimulatory domains that essentially cause that T cell to grow rapidly, to expand rapidly in the body, multiplying to more cells that are all capable of engage with more myeloma cells and kill more myeloma cells. So it's a chain reaction. That process of producing those T cells takes about 4 weeks. Sometimes shorter and sometimes longer. Of course, that has some challenges because we have to make sure that the disease stays under control or not causing the patients to become too sick in this mean time, and has all the logistics challenges of manufacturing one batch of cell for each therapy. So I think many of us are in the pursuit of an off-the-shelf option that would be kind of from a universal donor that would greatly cut the time and the logistic complexity of CAR T cell therapy. If you can move to the next one. So this is kind of the journey from the patient. I think a lot of the journey actually is before day one, is essentially finding the right facility, the right program, finding make sure the patient is the proper candidate, get insurance approval, and get a slot for collection of the cells and for manufacturing. Once all this is clear, the patient undergo a one-day apheresis. For those of you who had transplant before, it's similar, but it's not the same because you don't have to do mobilization. We're not collecting stem cells, we're collecting T cells that are already in the blood. So you just go there, get to IV access, and the apheresis, take those cells from the blood. The manufacturing takes 4 to 6 weeks. Interesting, before you just give those cells back to the patient, we have to do what's called lymphodepletion, which essentially literally means killing the lymphocytes in the body. And that is quite important because you create an environment where the patient does not have a lot of lymphocytes. So your body is responding to that by producing the right soup of substances we call cytokines that would allow growth of lymphocytes. So it creates the perfect environment to infuse those T cells and for those T cells to grow, expand, and engage into the cancer. Usually after that, we have a follow-up that's about 2 weeks. Oftentimes that's spent in the hospital, or most of that in the hospital, where we're watching for the more acute and oftentimes more concerning toxicity. And then there's a longer follow-up when we deal with some other challenges and we follow for disease response. Change the next one. So we have 2 CAR T cell therapies that are approved. One is called Abecma. That was the first one to be approved. The other is called Carvykti. That was the second one to be approved. They have some subtle differences in how they are dosed, but the approval is essentially identical. It's for patients who have had 4 or more different treatments, or 4 or more different regimens, and whose disease has been exposed to an IMiD like Revlimid or Pomalyst, a PI like Velcade or Kyprolis, and an anti-CD38 monoclonal antibody like Darzalex or Sarclisa. Next. So this is very important. I mean, transplant and CAR T currently occupy very different spaces in the myeloma setting. You know, autologous transplant is a defined therapy as part of the initial treatment, while CAR T cell is later on, currently for relapsed or refractory disease. However, is inevitable to make some contrast and outline some differences, because those things are relatable in a way. Oftentimes it's the same team. You undergo apheresis, you get some chemotherapy, you get some cells infused into you. You go to the same hospital, see the same specialists in many circumstances. So it's important to highlight those differences. And I use that very often because many patients, as I said, have had a transplant before. And the first thing they want to know is that the same? Is that worse or better? So there are very important differences. One is both you collect cells. The cells that we collect, as we said, is very different. With the transplant, the cells themselves do not treat the cancer. The cells are there just to support the high-dose chemotherapy. They're there to make the high-dose chemotherapy safer. In CAR T, the cells are what treats the cancer. They are cancer fighters, cancer killers. The chemotherapy that we use in transplant is the cornerstone of the treatment, is high-dose melphalan, which is great, but has quite a bit of toxicity, including hair loss, nausea, vomiting, diarrhea, weight loss. With CAR T, the chemotherapy is much lighter, is oftentimes given outpatient, barely gives nausea, and you don't lose your hair, you don't have the nausea, the diarrhea. And the intent of that chemotherapy is, as I said, is to prepare the immune system to welcome the CAR T cells. So because of that, the side effect profile is very different. I mean, transplant, we know fatigue, nausea, diarrhea, weight loss, hair loss. For CAR T, you don't have any of that. The challenges become what we call cytokine release syndrome, which is, I explained to the patient, is when you have a flu, for example, you have fever, you feel body ache, and that is driven by your immune system reacting to the virus. Here we have a little bit of that phenomena in overdrive, is the immune system being activated very quickly and in a very strong way. So you have fevers, and you can have changes in blood pressure, changing in breathing, related to the T cells expanding and engaging with the cancer. That is, fortunately, in the vast majority of cases, short-lasting and amenable to successful management with some interventions that we have to try to control that chain reaction. Next. So those are the data that we have for patients with triple-class refractory, triple-class exposed myeloma. As I said, the response rate is around 30%, and most patients are progressing after 3 to 5 months. Next. Now, if you put that in contrast with CAR T, you can really get an appreciation for how transformative those therapies are. And so in the same disease setting where conventional therapies will produce 30% response, now you have agents that produce 70 or 80% or more responses. In the initial trial with Carvykti, as high as 96%. And most of those responses are deep responses. You see, in the Carvykti case, the majority of patients are changing what's called stringent CR, which is the best category of response. In the case of Abecma, still the vast majority of patients having VGPR or better. Next. Now, what are the side effects? So some of there's two what I call signature side effects. Those are the two things that we spend the most time discussing with the patients. One is that cytokine release syndrome, which is that storm of those substances in our body that are responsible for coordinating the immune reaction. And that happens usually at the end of the first, beginning of the second week. It depends a little bit in what CAR T cell you're talking about. It's usually short-lasting, usually a few days, can be as long as 5 to 11 days. The key manifestation is fever, When it's more intense, you can have difficult breathing, nausea, headache, the speeding up of the heart, and low blood pressure. There are some therapies that we use to ameliorate or mitigate that reaction. Tylenol for fever. There's medications that block something called interleukin-6, which is one of those cytokines, which is the main mediator of that reaction, and even corticosteroids. I think on the early days of CAR T cell, not only for myeloma, but for other cancers, there was a bit of reasonable concern that if I interfere with that reaction by using some of those medications, I could somehow decrease or reduce the efficacy of those CAR Ts. And now we know that's not the case. We can quite liberally utilize those agents for the patient's safety without jeopardizing the efficacy of the CAR T cells. The other reaction that oftentimes concerns patients is something called immunoeffector cell-associated neurotoxicity syndrome, which is something that or ICANS for short, is something that's very specific to this treatment. And the mechanism of that is still not fully understood. The prevailing explanation is some of the cytokines that your CAR Ts are driving actually can go into the tissues around the brain and cause some transient changes on how the brain is functioning. And that can manifest with headache, confusion, some difficult writing. So one of the things that we do routinely, I think, in any CAR T center is, as we round on the patients daily, they're asked to write the same sentence over and over on a piece of paper so we can monitor small changes that could be indicative of ICANS. In more severe cases, you can have seizures, delirium, or even swelling of the brain. Fortunately, in myeloma, that has been far less common than it is in other cancers, for example, CAR Ts that I use for leukemia or some types of lymphoma. And the vast majority of cases are what we call grade 1 or grade 2 on a scale 1 to 4, so they're not very serious, and they tend to be very transient. But it is nevertheless a risk that, that we have to discuss with the patients. And the things that we do is, as the earlier sign of that, we institute medication to prevent seizures. And the most effective therapy for that is indeed corticosteroids. So usually when the patients develop ICANS, they receive a few days of high-dose steroids with often complete resolution of the symptoms. Next. Now, now that we understand CAR T cell, it's easier to understand bispecific antibodies. As I usually tell the patients, the idea is the same. You want to take the T cells in your body that are professional killers of other cells and redirect that, repurpose that to fight the cancer. Well, one way is what you just heard. Take those cells out of your body, put a gene, grow those cells, bring it back. But that has, of course, some barriers, including the collection of the cells, the manufacturing time, and so forth. The bispecifics try to accomplish that, or actually do accomplish that in a kind of a faster way. Instead of modifying the T cells, it essentially establishes a bridge, establish a connection. And if you want to sound very fancy, we use immunologic synapses to take the T cells that are already flowing by your body and putting those T cells in connection with the myeloma. So I think everybody who ever dealt with myeloma as a patient, as a family member, or as a healthcare professional understand what an antibody is, which is a protein that targets and binds to a specific protein. Interesting, our antibodies in our body have one specificity. They can bind one thing and one thing only. Well, the idea here is you engineer an antibody to bind two things. One thing in the surface of the cancer cell and one thing on the T cells. That's why they're called bispecifics. And by doing that, they bring those two cells together. And when the T cells are forced to be close to the myeloma cells, that's enough for them to be activated and to eventually kill those myeloma cells. So, of course, the advantage of that is an off-the-shelf product. We don't have to produce one batch for each specific patient. We're now fortunate that we have 3 bispecific antibodies approved, teclistamab, elranatamab, and talquetamab, and we have several others that are in clinical development. Next. So teclistamab was the first bispecific to be approved about a little bit over a year ago. It produces a response in about 63% of the patients. And similar to what we saw with CAR-T, most of those responses are complete responses or deep responses in one way or the other. And this is a population that is actually as advanced, if not more advanced, myeloma than the population reflected on the CAR-T cell. And those responses can also be very durable. You see here a median duration of response that is close to 2 years and even higher if the patients are among those who achieve a complete response. Next. Elranatamab was approved more recently. Is also a bispecific that binds to BCMA. And again, you see very similar numbers with a very high rate of response, mostly deep response. And because this is ongoing therapy as opposed to CAR-T cell, which is a one-time treatment, those responses tend to be very durable. You see here the 15 months after the onset of therapy, the majority of the patients are still doing well without progression. Next. Now, while teclistamab and elranatamab binds to BCMA, talquetamab binds to a different protein on the surface of the cancer cells called GPRC5D. And the response, this bispecific is also approved as of August, I believe. And it was approved in 2 different schedules that are that we can choose from. One is with weekly administration, the other one with this every other week administration. And they both produce very similar high rate of responses and responses that, again, can be quite durable. Next. So there are some toxicities, of course. If you are working in a similar way than CAR-T, you can expect some of the similar side effects. So cytokine release syndrome are also very common, as it is with CAR-T cell. What I tell patients is the difference with CAR-T cell, you kind of unleash the cells in the body, and all you can do is try to give other interventions to mitigate the side effects if they become too severe. With bispecific antibodies, in a way, you hold the pace of those reactions, because you can always stop, you can always delay or omit the next dose if the reaction becomes too intense. We also learn on the development of all those bispecifics that are approved that the reactions can be much easier, much more tolerated if you don't give the intended dose right at the beginning. You do what's called stepping up dose. You give a tiny dose, a couple of days later, you give an intermediary dose, and a couple of days later, you give the intended dose. And that gives you control of the pace of their reaction and greatly improves the risk of cytokine release syndrome. Neurotoxicity that we discussed for CAR-T is far less common and far less severe. And the challenge that we have tends to be low blood counts, that oftentimes patients need what we call growth factors, which are shots that help the neutrophils, the white cells, to improve. And we can have also infections because those therapies cause the immune system to weaken away, lower the production of normal antibodies, and cause some of the normal T cells in the body to not work properly. So there is now a roster of interventions, of preventions that we do to help reduce the risk of infections including something called IVIG, including some preventive antibiotics and so forth. In the case of talquetamab that binds GPRC5D, we have a very unique set of side effects that are related to that expression of GPRC5D in other cells in our body. And that causes, for example, nail changes, can cause some rash and some peeling of the skin, and things not tasting right, what we call dysgeusia. Fortunately, those side effects can be disturbing, can be uncomfortable and inconvenient, but they are rarely dangerous or life-threatening. And they also tend to get much better with time and sometimes with some adjustment in dose and schedule. Next. So in conclusion, we have several new classes of drugs, including CAR T-cell and bispecifics, that are already helping patients with triple-class refractory myeloma. The results are really far, far superior what we could accomplish before with conventional chemotherapy or reshuffling or existing classes of agents. And I think I shared the enthusiasm of my colleagues that the best is yet to come as we learn how to use those therapies better. And we, in combination with other myeloma drugs that are existing or yet in development, and we find better uses for those agents, even in patients who don't have as heavily pretreated myeloma as those represented on these studies. Thank you so much, and I'm very sorry I only have to be able to stay for the first couple of minutes of the discussion.
Oh, thank you. No problem, Luciano. Thank you for that excellent presentation. Before you sign off, what message do you want to give the patient listeners about relapsed refractory myeloma overall and specifically triple class? And then me and Andy can converse thereafter.
Yeah, I think that's a great point to direct on our patients, and I apologize if it's a little bit self-serving, but I think if you can take away one message from this seminar is that myeloma care is becoming very complex and complicated in a good way, because there's a lot to be done and a lot of options, and that requires increasingly more specialized expertise. So even if you don't live next door to Dr. Vij or Dr. Yi, and if you have your doctor at home that might be miles away that does the everyday treatment, having a myeloma expert on your team from the very beginning is crucial. You want to, if possible, be hearing about the options, be weighing in the possibilities, and have access to the treatment centers that are capable of giving you those more advanced and more promising therapy early on before you're dealing with a progression or particularly an aggressive crisis like progression. So have good advice of experts that spend their whole careers treating and counseling myeloma patients. And a lot of the innovations are coming to us through clinical trials, and be willing to be open to those options, because that's how transformations first come to patients.
Thank you, Luciano. I know you have to go, so you're free to sign off, and me and Andy will take it from here. I request the attendees, if they have questions, to put it in the Q&A box. So, Andy, I think clearly there's a lot of new exciting stuff going on. As I kind of divide myeloma eras, there was the era till 2000 of what we call cytotoxic conventional chemotherapy, be it transplant level, high intensity, or combinations of drugs. And then for 20 years odd, it was the novel therapy era. You talked about several of those: the immunomodulatory drugs, the proteasome inhibitors, the CD38 antibodies. There were others, including selinexor, SLAMF7 antibodies, Amplicity. But now we're into a new era for the last, say, couple of years, the CAR-Ts and the bispecifics. So how do you think through when you have a patient that has been through the drugs that you yourself talked about? How do you think through which of these now we have 2 CAR T cells, 3 bispecifics, more to come? How are you thinking through how to treat these patients?
Yeah, I think no, I completely agree. I think the past few years has really been incredible, for us taking care of patients because we have all these new options we can offer patients. For patients, so I completely agree with what Dr. Costa was saying about, clinical trials. And I think participation in clinical trials is really critical, for in terms of how we move the field forward and also in terms of how we give patients access to some of the newest therapies available. Now, when we think about the what gets complicated, and you're pointing out is we have options, for patients who have triple class exposed / refractory in 4 prior lines. You have 5 potential options you can choose from. You can choose from CAR T, like the Abecma or Carvykti, or you could choose from the 3 different bispecific antibodies, the teclistamab and elranatamab and talquetamab. And then how do you choose between among the 5? Because they all have exactly pretty much the same language in terms of the approval. I think for us, fortunately, access to CAR T for us has been a lot. And I realize I'm maybe speaking from a silo because, what I say may not be applicable to every center, but, for us, access to CAR T has been a lot easier for patients than it has like compared to a year ago, 2 years ago. And I'm sure I could probably speak for you and Dr. Costa. It just feels different, in terms of slot availability. It's not as constrained as it was before. And, as Dr. Costa mentioned in his presentation, some of the response rates with CAR T are really, unprecedented. And the fact that you could have an option where, for patients, it could be one and done, for patients who are at their 4th line of therapy, I think a lot of patients are ready to kind of try something different, because patients on their 4th line, they're coming all the time. And when you have this CAR T, it allows you to move on and have a break from treatment. So generally speaking, for a patient who comes to see us, who's, we tend to lean with CAR T first as the option. So we tend to think about either, ide-cel or cilta-cel. Now, just based on the response rates. Now, of course, not every patient can get access to a CAR T because of, there are some logistics involved. You have to have you have to be able to travel to the facility, and you have to have a caregiver with you for the first 4 weeks ballpark after the infusion. So those are challenges. Now, the bispecifics are also options. And so that for me, since we have access to CAR T, I think of more of those bispecifics for kind of really specific patient scenarios. And I think the hope is that, right, the CAR T is kind of burdensome and kind of logistically complicated, or you have to be able to travel to a center that offers the CAR T. And the hope is that in the not too distant future, these bispecific antibodies, which have efficacy, approaching CAR T, that could be more widely available, in the community. I think I think we're starting to see that happening now, because right now, because of the monitoring required for the bispecifics, does impose kind of a burden. But I think as we get more exposure, more familiarity with it, I think we can start seeing, outpatient administration of bispecifics be more of a thing. So patients can have access to some of this latest therapy closer to home.
So obviously, there's no one rule that fits all. CAR Ts are, as we call, the one and done, and obviously that is something that is, attractive to patients. But what about, can you use them both in the same patients?
You mean use both CAR Ts or use both bispecifics?
No, a bispecific to BCMA and a CAR T to BCMA.
So the other thing, just another nuance to point out with the in terms of using both, is that generally speaking, there's some appreciation that patients who've had prior bispecific antibodies, say teclistamab or elranatamab, patients who've had that therapy first and then they go into CAR T, that there's some theoretical concern that prior exposure to a bispecific targeting BCMA you may not have the same durability of response if you've had subsequent CAR T with targeting BCMA. So based on that, we try to prioritize BCMA CAR T before giving a BCMA bispecific, because of that concern where you may not necessarily have the same response. Now, this is all based on small numbers of patients, and I think we just need more data just to know how true is this in practice, because it's only based on really a handful of patients that people are making this extrapolation. Now, we don't know if exposure to, say, talquetamab or GPRC5D bispecific antibody, which if you have exposure to that, does that affect subsequent BCMA CAR T? That we don't know. And I think that's something that we'll have to explore. And also just using, I think one thing that Dr. Costa was, is that for bridging therapy, sometimes you do patients who, because patients who are coming to CAR T generally have pretty active disease. And for bridging therapy, I think one thing we want to know further is that can you use a GPRC5D bispecific as bridging therapy? So that's something we're just starting to explore.
So obviously bridging is once you've collected the T cells and you're waiting for those to return from the manufacturer, what do you do in that time? Now you did, talk about bispecifics and then going to CAR T, having some concerns. What about the reverse?
Yeah, the reverse is not as, in the clinical trials that have looked at, bispecifics following CAR T, the response rate is about 50%. So instead of 60%, it's more like 50%. So with CAR T, so people have this perception, once you have CAR T, there's like nothing after CAR T. But that, if anything else, there are plenty of other options you can do after CAR T if for whatever reason doesn't work as well. So we have patients who have had prior CAR T, and then we're using the bispecific antibody, and we are able to achieve responses, and patients are able to get back, the response that they had before. So I think certainly you can use, teclistamab, elranatamab, as well as the GPRC5D bispecific. I think over time, this is based in 2023. I think in the future, we might be able to better understand, how patients become resistant to, CAR T. Is it from loss of BCMA or other factors? And that might influence choice of subsequent therapy.
So one of the questions from the attendees is, what about combining the two bispecifics, and would you use one then add a combination?
Right. So I think that's some of the most exciting developments. And I think maybe the person posing the question was referring to the redirect study that was presented at ASCO back in June. And they looked at the combination of teclistamab and talquetamab. So you're doing both at the same time. And I think what was remarkable about that is that I think the response rate went from about 60% to about 80%. And not only did you have improvements in response, but we were talking about extramedullary disease before and how that can be challenging to treat. And the combination of teclistamab and talquetamab had really effective responses in extramedullary disease. So that's really exciting to see that as a combination. Now, am I doing that in clinical practice? Not necessarily, because of potential challenges in reimbursement. I think if insurance was okay with it, maybe once it gets an NCCN listing or something, I think maybe we'd have more, we have more data to support using it. But I think that combination could be really effective. And and then the other related to that is people are looking at CAR T targeting two things at the same time. So theoretically you could do CAR T targeting BCMA and GPRC5D. There's also CAR T targeting GPRC5D. And speaking of combinations, we're talking about these bispecifics. We just given teclistamab or talquetamab or elranatamab just as a single agent. But as people know, myeloma therapy, we're just talking about from doublets to triplets to quadruplets for initial therapy. And people are looking at combinations with these bispecifics. So, at this ASH meeting, there will be some data looking at talquetamab combined with pomalidomide, and some of the trials that are ongoing looking at bispecifics for earlier disease are looking at combinations with, CD30 antibody with a bispecific in combination with, say, pomalidomide, for example. So, the field there's going to be another iteration how we use these bispecifics as well. And just related to that too is when you use them in combination, you potentially could get that augmentation efficacy that could get closer to that CAR T level of efficacy, but at the same time, you can do it closer to home.
So talking about some of the practical aspects of giving these treatments. So how do you manage the patients who are getting a CAR T, a bispecific? Are they in the hospital all the time? How long do you have them stay? If they're in the hospital, how long do they stay in the general area? Both for CAR Ts and bispecifics, how are you going about it?
Right. No, so for CAR T, because you have to monitor, for CRS and neurotoxicity, so patients are generally in the hospital for about a week to 10 days to monitor for those side effects. Because once you have cytokine release syndrome emerges, it's important to have access to drugs like tocilizumab to kind of calm down the immune system. So generally speaking, patients are in the hospital for a week, week and a half, but then they do have to stay in the area, within 30 minutes of where they receive the cells. So that way they have to be, they have to stay around the area, and then they have to have a caregiver with them. And so they have to be close to the center for about 4 weeks from the time of infusion. So that's kind of a big ask for patients and their families and caregivers. So that's kind of the major limitation with CAR T. And then, thankfully, with programs, we have programs, sponsored by the companies where you can have housing support. So a lot of patients travel from an hour, 2 hours, 3 hours away. So patients can travel here and stay locally and have some housing assistance to make it practical. Now, once they get past the 1 month mark, then typically, the patients are followed by their local oncologist. But it is kind of a big ask for that first month, but I think it does pay off significant dividends in terms of. Now, I know, Dr. Vij, you have patients too. We all have patients who were just getting lots and lots of treatment, but then they get CAR T, and then their life just changes, right? They can go on vacation, they can leave, they can do things that they couldn't do before because of some of the dramatic responses that they've achieved. With the bispecifics, there's also the similar level of monitoring for cytokine release syndrome and neurotoxicity, and the way that they've been improved, they do require a hospitalization. So for example, for teclistamab, we tend to give it on days 1, 3, and 5, and then they're in the hospital for about 48 hours after their full dose, which is given on day 5. So that ends up being there in the hospital for about 1 week, and that's kind of the version of giving teclistamab in 2023. I think with elranatamab, you can leave the hospital on day 4. Now, that's how we think about giving it in 2023. But I imagine that over time, people are starting to report using these bispecifics as an outpatient. And I'm hopeful that, next year, in the months ahead, that we can start to think about giving them more as an outpatient rather than the burden of having somebody, coming into the hospital.
So what about the CAR Ts as an outpatient?
Oh, so CAR T is an outpatient. So that with, for example, with cilta-cel Carvykti, we are starting to give it as an outpatient, knowing that the cytokine, as Dr. Costa was mentioning, the tempo of when CRS emerges is somewhat different between, Abecma or ide-cel versus Carvykti cilta-cel. With Abecma, the CRS happens within 1 or 2 days. So based on that, it's important for those patients to be more closely monitored, and hence it really motivates the hospitalization. With ide-cel, with cilta-cel, the onset of CRS tends to be later on, like day 5, day 6, day 7. So we are starting to give patients we are giving the cilta-cel as an outpatient, but with frequent monitoring. Maybe we ask them to come in the clinic on a daily basis in the beginning, without necessarily hospitalized, but we would hospitalize them like around day 5, because then we know that's when the CRS can start to occur. I mean, there are other centers where they have other arrangements where maybe they have a housing and their infrastructure is set up better to give it as an outpatient. So there can be some heterogeneity amongst institutions.
So one of the things that patients often ask, since they've already been to a transplant often before they're getting a CAR T these days, is it as bad as a transplant? Is it as harsh as a transplant? What do you tell them?
Right. So I think, with transplants, when I think about autologous stem cell transplant, your patients are getting old school heavy duty, old fashioned chemotherapy. And because it's old fashioned chemotherapy, they do have the old fashioned side effects of chemotherapy, such as hair loss and some GI side effects. With CAR T, I think the ride with CAR T is actually smoother than it is with high dose chemotherapy. So for patients where I would be, kind of hesitant to give them high dose chemotherapy, I feel completely comfortable giving them, CAR T patients. Now, patients in, again, eligibility for high dose melphalan really can be heterogeneous across, patient populations, but certainly for patients over 75, for example, I'd feel completely comfortable giving them, CAR T as opposed to, in terms of their experience would be much easier, I think, with CAR T than it is with high dose melphalan. And I think that relates to with CAR T, you do get some chemotherapy to provide space for the cells to grow, but that chemotherapy isn't that intensive. And then in terms of the side effects of CAR T in the hospital, it really is just monitoring for cytokine release syndrome neurotoxicity. But cytokine release syndrome, that can be generally be managed with tocilizumab. And I think for patients, majority of patients who are getting CAR T, it's pretty much drama free in terms of, majority of them will have fever, but for most of them, it's a relatively, it's not too. I think it's an easier experience than the side effects from bone marrow transplant.
So, Andy, one thing you mentioned is that you're fortunate that you are at a center where CAR T access has improved. But is there a patient who you would actually go to a bispecific rather than a CAR T?
Well, there are a couple. I think there are a couple niche cases I'm thinking about. So the patients where I think about giving the bispecific would be, these are really niche cases. So I mean, I have a patient who is a Jehovah's Witness and would not, and blood transfusions, blood product support wasn't an option for the patient. So for this patient, a bispecific antibody was a better option for the patient, and that patient, that patient's doing great. I think for for patients who are very, there are some patients who don't have the logistics to be able to have that 1 month stay in 30 minutes within the hospital. So for those patients, I'm giving the bispecific as well. I have other patients who they're really kind of on the frailer side, and I think the bispecific is easy. I mean, really frail. I think for those patients, the bispecific is easier. But for the patients who have really, aggressive, explosive relapse disease, I haven't been using the bispecific as much because I think if you have really explosive, aggressive disease, I think that's where the old-fashioned chemotherapy can play more of a role. And I would use that as a lead-in to get the CAR T. Now, I think the one of the questions was using like 2 bispecifics together. I think, somebody who had a really aggressive relapse, maybe I would feel maybe if you did the combination of teclistamab and talquetamab, maybe that would be one approach. But I think as a single agent, the bispecific, if you had a really aggressive relapse, I'd be kind of hesitant to use a bispecific in that particular patient population.
So obviously you talked to us about early, relapse disease, that is people who had 1, 2, or maybe even 3 relapses. What if you were giving this lecture 5 years from now? We have all these bispecifics and CAR Ts in later lines of therapy. Where do you think 5 years from now these will be?
So right now, the bispecifics as well as CAR T. Well, so a couple of things. I think the bispecifics are being, we're involved, they're being evaluated 1 to 3 prior lines, and they are being evaluated in newly diagnosed patients. And I think 5 years from now, these bispecifics will be used in patients in 1 to 3 prior lines, as well as in newly diagnosed patients. Because as we get, and these trials are looking at bispecifics being given as an outpatient. Now, I know that I said I had some hesitation about using a bispecific before a CAR T. But I think if you're giving an earlier lines or newly diagnosed, I think it's different because I think in that disease state, you probably will have, that's the best opportunity to get the deepest possible response. And I think the bispecific in that setting may offer you a chance to get the deepest possible response, especially when you're giving in combination. And I'm also thinking in the future, we'll probably figure out how do we use CAR T after bispecifics, or maybe there'll be something else beyond CAR T. So I think that in the future, 5 years from now, I think bispecifics will be incorporated more earlier in the disease course. And that also applies to CAR T, because right now, we're saying the CAR T is approved for 4 prior lines, but I think there's a real, there have been 2 trials which have been recently presented that looked at ide-cel or Abecma after 2 prior lines, and then Carvykti after 1 prior line. And that data has been presented, and I think it's theoretically possible. It's theoretically possible that we could have access to, say, ide-cel after 2 prior lines at the end of the year. That's theoretically possible. That could be approved, and it's theoretically possible that cilta-cel could be approved for 1 prior line by the middle of next year if everything goes according to plan. So I think that this discussion will take on another layer, right? So I'd have to redo this whole slide deck with 1 to 3 prior lines. It's going to be, I imagine that next year probably look different. So, and then I think the same paradigm about how do you choose really would apply in terms of, again, the disease characteristics and patient preferences as well. I should also mention too that, 5 years from now, we were talking about the bispecifics and CAR T, but there are other drugs which are in clinical development, right? So right now, their next generation pomalidomides being under active investigation. So drugs like iberdomide and mezigdomide, they're in development right now. And these are drugs that are even more potent than pomalidomide. And I bet it's possible 5 years from now, those drugs could be available as well. And then we'll be having the same discussion about combinations as well. Maybe you combine the bispecific with like mezigdomide or something. So there are all these new developments in the future.
So talking about the future, just in the last few minutes, what do you think in the next 5 years will be the major trends that we will see in myeloma? We've talked about moving these drugs up front, and we've talked about greater utility of these agents, but will we be treating myeloma differently in terms of who goes to a transplant? Will transplant still be part of treatment? How will we use this assay called the MRD, the molecular residual disease assay? Will that be something you foresee in having an important place in decision making?
Right. So, I think 5 years from now, I think we're myeloma therapy, we just kept adding on therapies, 2 drugs, 3 drugs, 4 drug combinations. Maybe people do 5 drug combinations, and then we were just talking about combining bispecific. So I think, myeloma therapy just keep adding and adding things. But I think the future will be about maybe peeling back from keep adding on things. So I think in the future, we'll be talking more about, say, fixed duration of therapy, and then, using, MRD testing to better identify patients who can, say, come off treatment. And I think that data is starting to emerge where people are reporting data looking at MRD testing and saying, okay, patients who came off therapy and they were MRD negative for a year, they did okay. They did fine, right? And I think what we're really waiting on would be some randomized trials going on right now. They'll provide us with randomized data to really better identify the patients who can come off therapy, because I think we would all love a fixed duration of therapy to say you can come off all, because the best therapy is no therapy, right? So I think that'll be one. I think that data will emerge in the next 5 years. Now, related to the MRD testing, right now the MRD test requires, bone marrow biopsy because it's based off the bone marrow aspirate. And I'm hopeful in the next 5 years, we will have we'll have testing off of the peripheral blood. I mean, there's that's available right now. Actually, it's starting to be in the process of being commercialized, where you can order a peripheral blood test that approaches or maybe even exceeds the sensitivity of MRD testing in the bone marrow. I mean, right now I know the bone marrow MRD is the gold standard, but I think in concert with the MRD data is also better assessment of the MRD with using peripheral blood. So I think hopefully 5 years from now, we will have, patients don't have to have bone marrows. Patients can come off therapy. We can use a blood test to say, oh, you can stop treatment. So I think And then we will have therapies that allow us to get to that level of response more effectively with better tolerability. So I think these are all really, potential exciting developments in the next 5 years.
So to end, Andy, a lot of patients ask, is this a disease that is curable, or is it going to be cured with these new treatments? I think that we all have patients that are sometimes in a remission, or sometimes have a very small paraprotein in what we call a functional remission, even 15, 20 years out. Even today we have them.
Yeah.
And do you think that with these novel therapies, there'll be more of them to come?
Yeah, I think, there are patients we're treating right now who probably could be cured. We just don't know because they're on they're on maintenance therapy. And I think with these newer therapies that we're getting these deeper, more durable responses, I think we are going to potentially increase, the cure rate, I think we can approach a cure, or certainly a functional cure. In concert with this too would be, understanding better the molecular genetics behind the disease as well, to better target these therapies. So those are all other developments. But I think as we get these therapies that have these deeper responses, I think I can only be more hopeful about that as being more and more of an option for patients.
I agree, Andy. I really do think the best is yet to come. We made tremendous progress in this disease. When I started out in this field 25 years ago, it was a struggle to get patients out to even 5 years after diagnosis. I think the number of patients in my clinic today that are more than 10 years out is a growing number, and I'm sure you're
absolutely
seeing. And I think that if we can transform this even into a chronic disease, which I think we're doing already, I think we would have helped a lot of patients.
Absolutely.
So, well, Andy, I want to thank you for spending the time to educate the patients about where myeloma is moving. I also want to thank our sponsors, without whose assistance this webinar would not have been possible, Sanofi. And to end, I want to thank all the attendees, and I would just ask that they take a little survey before they leave to tell us how we did, and we want to do better in the future. So thank you very much, and everybody have a nice day. Thank you, Andy.
Thank you. That was great. Thank you. Have a great weekend, everybody. Thank you.
Thank you.